Hello, my name is Saad Abushadi. I'm a resident at the Wellington Regional Medical Center. Today, I'll be discussing a case of a 68-year-old male with an advanced presentation of Kartagener syndrome, a rare genetic disorder characterized by a triad of chronic sinusitis, bronchiectasis, and situs inversus. Kartagener syndrome is a form of primary ciliary dyskinesia where defective ciliary function leads to impaired mucociliary clearance, predisposing patients to recurrent respiratory and sinus infections. The patient's condition was further complicated by poorly controlled diabetes and significant kidney dysfunction, highlighting the complexity of managing multisystem involvement in this syndrome. The patient presented to the emergency department with a 10-day history of persistent shortness of breath. 10 days prior, he had experienced a significant episode of hemoptysis, producing about a cup of blood. He was evaluated at another hospital where bronchoscopy was performed, but it did not identify any bronchial source of bleeding. The hemoptysis was attributed to trauma from heavy coughing, and he was discharged after the bleeding resolved, although his shortness of breath did persist. His past medical history was significant for asthma, diabetes with an HbA1c of 9.2 indicating poor glycemic control, and Kartagener syndrome, which had led to recurrent lung infections throughout his life. The patient reported self-medicating with levofloxacin for these infections. His surgical history included a quadruple cardiac bypass. He denied any tobacco, alcohol, or drug use and reported minimal prior hospitalizations. Family history revealed 2 reported healthy adult sons and a deceased brother who had undergone a heart transplant 20 years earlier. Upon presentation, his oxygen saturation was 78% on room air, necessitating 4 liters of supplemental oxygen via nasal cannula. Cardiac auscultation revealed a normal sinus rhythm with heart sounds localized to the right side of the chest due to situs inversus. Lung auscultation identified rales throughout all lung fields. During his hospitalization, imaging confirmed extensive bronchiectasis, particularly in the lower lobes, as you can see in the CT images, along with multifocal pneumonia. Additionally, the patient was found to have significant renal dysfunction with a creatinine level of 7 milligrams per deciliter. On admission, suggestive of chronic kidney injury, likely exacerbated by his poorly controlled diabetes and chronic hypoxia from recurrent lung infections. Throughout his hospital stay, the pulmonology team managed his bronchiectasis exacerbation and pneumonia, which led to significant clinical improvement. However, due to the severity of his condition, the patient still required supplemental oxygen at discharge and was sent home with ongoing oxygen therapy. On the nephrology side, the patient's significant renal impairment was evaluated, and dialysis was recommended as the only viable intervention to address his chronic kidney disease. However, after a thorough discussion of the risks and potential outcomes, the patient declined dialysis. This case highlights the complexities of managing Kartagener syndrome, especially when complicated by other chronic conditions, such as diabetes and renal dysfunction. The extensive bronchiectasis seen in Kartagener syndrome contributes to chronic respiratory complications, including recurrent infections and chronic inflammation, which can exacerbate lung damage and hypoxia. This in turn can place additional stress on the kidneys, especially in the context of poorly controlled diabetes as seen in this patient. The chronic hypoxia, systemic inflammation, and recurrent infections likely contributed to the patient's chronic kidney injury, further complicating his clinical picture. Recurrent use of antibiotics like levofloxacin for self-treatment of lung infections may have also contributed to nephrotoxicity, compounding his kidney issues. The patient's decision to decline dialysis despite the severity of his kidney dysfunction emphasizes the importance of respecting patient autonomy, particularly in complex multisystem cases like this one. Managing such a patient requires a multidisciplinary approach involving coordinated care from pulmonology, nephrology, and other specialists to address the intertwined challenges posed by his respiratory, renal, and metabolic conditions. In conclusion, this case underscores the importance of a comprehensive and multidisciplinary management strategy in patients with Kartagener syndrome and other chronic conditions. The patient's acute or chronic respiratory failure, multifocal pneumonia, and significant renal impairment demonstrate the severe interplay between his chronic conditions. Ongoing follow-up and outpatient care will be essential in optimizing his long-term outcomes. Thank you.